My name is Emma. I'm a fourth-year resident at U of T, and today I'll be discussing our work developing techniques and reference values for radial motor nerve conduction studies recorded from triceps and ECRL. I have no disclosures. Nerve transfer surgery can improve upper limb function in patients with cervical SCI. This involves coapting a functional donor nerve to a non-functional recipient nerve below the level of injury. The timing of nerve transfer surgery depends on the status of lower motor neurons within the recipient nerve. When there is lower motor neuron damage, the target muscle undergoes irreversible atrophy and fibrosis within about 18 months, so clearly nerve transfers into this area are time sensitive. The status of lower motor neurons can be determined by preoperative electrodiagnostics, and it has been shown that the best predictor of lower motor neuron integrity is the CMAP amplitude. There are no existing nerve conduction techniques or CMAP amplitude reference values for triceps and ECRL. These are two possible recipient muscles for nerve transfers to restore elbow extension and wrist extension respectively. So we set out to develop these techniques and to obtain reference values for these muscles in a healthy population. We conducted a prospective study of 25 participants, 14 females, who were healthy with no symptoms, risk factors, or history of peripheral nerve disease. We positioned the subjects as shown to expose the axilla. Recording montages are described here. For triceps, the active recording electrode was over the long head of triceps with the reference over the olecranon. And for ECRL, the active recording electrode was 2 centimeters distal to the lateral epicondyle with the reference over the medial epicondyle. Our stimulation site was in the axilla at the level of the pec major tendon insertion, just over the axillary pulse. We then marched the stimulator around until a visible triceps contraction was seen. Here is an example of the CMAPs we recorded, with triceps on the top and ECRL on the bottom. The mean triceps amplitude was 15.5 millivolts, and ECRL was 11.5 millivolts. The distribution of results was skewed, so with mathematical transformations, we determined the lower limit of normal to be 8.1 millivolts for triceps and 6.2 millivolts for ECRL. We also found that the ratio of ECRL to triceps CMAP amplitudes was about 50 to 100%. And finally, because distances from the stimulation site to the active recording electrode were not standardized between subjects, we did not calculate reference values for CMAP latencies. In conclusion, we described techniques for a unique set of nerve conduction studies to evaluate triceps and ECRL. The lower limits of normal CMAP amplitude are listed here. This can help with preoperative evaluation of lower motor neurons in order to guide timing of nerve transfers. Future directions include validating these findings on a larger scale or with direct intraoperative nerve stimulation. Thank you for listening, and feel free to email me with any questions.